ஆ, சரி என்ன இருக்கு இப்ப? 2 வாங்கிட்டு வரியா? எவ்வளோ? ஆ, சரி 2 3 வாங்கிட்டு வா. ஆ, எத்தனை ஆகும்? ஆ சரி. ஆ சரி. பின்னாடி ஆளு நிக்குது. இந்த வண்டி பார்த்து
Good evening, ma'am.
Hello.
Good evening, ma'am.
Yeah, good evening. So I'm kind of driving. I'll be on my way
I
back
was
home.
I was
So
thinking
I'll
along those
I'll I'll
lines
I'll try and be online. Please carry on. I've gone through
because
the
I think
presentation.
nobody else has joined in. Yes, ma'am.
Yeah,
So
yeah.
I
So
have
I'm just going to mute it for the time being.
yes,
And
ma'am.
I think I should make it back home in another 15 minutes or 20 minutes.
Okay, ma'am.
So
Okay,
but I'll be online in the car. Yeah. Okay.
okay, ma'am.
Yeah.
Thank you, ma'am.
Yeah.
Bye.
Thank you. Hello. So is the candidate there? Hello. Is the student there?
Yes, ma'am. Good evening, ma'am.
Yeah, good evening. So, has Dr. Kanagvel joined? No.
Madam, he told that Dr. Rajesh Sagai will be the host.
Okay, so if anybody from the advisors is there, I think we can start on time. Has Dr.
Yes, ma'am.
Sahai or anyone joined?
Yeah. I'm sorry.
Yeah, hi, Dr. Sahai. Good evening.
Good
Congratulations, first of all.
Oh, thanks.
Big time congratulations.
Yes.
Yeah. So I
Yes.
think you can initiate the proceedings so that
Yes.
I'm driving and I told madam that she'll take over. I'll be here online. Yeah.
Okay, that's fine.
It'll take me 10 minutes to reach home. Yeah.
No issues.
But
Please
I'm around. Yeah.
yeah,
yeah.
please drive carefully.
Yes. So I think we can start on time. Yeah.
So Dr. Piyush Chopra, is he there?
Yes, sir. Good evening, sir.
Yeah, Piyush, you can start.
Yes.
Right. Professor Gayatri, ma'am. I think she's not there. And Dr. Pratibha Bala.
I'm
Dr.
here,
Pratibha-
sir.
Dr. Sahai, one comment I
Yeah,
want
ma'am.
to make before I start off. I went through the girls' case proceedings that were sent to me. So looks like the candidate is prepared for writing a case report. So we will advise her according to that, and that currently take it up as a PG clinic case.
Okay, that's
Right.
nice.
Yeah.
That would be nice.
Yeah.
And Dr. Rachna Gupta, is she there, ma'am?
Yes, sir. Yes, sir. Am I audible?
So, yeah, very much, ma'am. So can
Thank
we
you.
start?
Yes.
So is my
So-
screen visible, sir?
Gayatri Madam also here, sir.
Yes, I'm here.
And we've got Dr. Srinivasan who's with us. And
Yes, sir. He is also
Okay.
here.
right, so let's start. Dr. Piyush, you can start your case.
Good evening, everyone. Today I'm presenting a case on phyllodes tumor of the right breast. My patient is a 55-year-old female who's of postmenopausal age, gravida 3, para
I
3.
think you should be a little loud.
Good evening, ma'am. My patient is a 55-year-old female who's of postmenopausal age, gravida.
Piyush, hang on. Piyush, your slides are
Ah.
the font is very small. We can't be seen at all. So can you increase the size? Okay. I mean, it can't be done now. Look, when you make a presentation, just make the font at least 14, right? Because this must be at least 8 or 10, which is not visible at all. Okay, go on.
I can't
try.
see anything.
So patient came with the chief complaints of rapid
Can you zoom little bit?
And make it Control plus.
Sorry, sir, it is not happening, sir.
Okay, let's continue. Go on.
Patient came with complaints of rapidly enlarging painless mass in the right breast for last 3 months. The growth was rapid, particularly over the last 6 weeks, and it was not associated with any associated symptoms. It was painless with no discharge and no skin changes. The patient observed a small firm lump in the right breast 3 months ago, and it was 6 weeks ago when she observed a significant acceleration in the mass growth. Currently, the patient presents for the evaluation of a large, rapidly enlarging mass. The mass is painless, associated with no discharge, no skin changes, and no constitutional symptoms like fever, weight loss, or malaise. The review of systems was unremarkable and no systemic complaints were there. Patient is on lisinopril 10 mg daily for control, and there's a case of hypertension. There's no history of malignancy. There's no history of diabetes mellitus. There's no history of chest wall radiation. There's no history of any other malignancies. She has history of uncomplicated cholecystectomy done 10 years ago, and there are no other surgeries. She's currently on lisinopril 10 mg for hypertension. There's no known drug allergies. Family history: her mother was diagnosed with breast cancer at an age of 75 years of age, postmenopausal age. There are no other first degree relatives diagnosed with any malignancies, and her father has no history of cancer, and siblings also have no history of breast or ovarian cancer. There's moderate family history with mother with late onset breast cancer, and no strong hereditary cancer syndromes pattern were identified. On physical examination, the patient is.
No, hang on, Dr. Piyush.
Yes, sir.
Summarize your history. Look, I just want to tell you, if you want to deviate from the normal presentation, right, there must be a reason for it. I mean, just crowding up your slide with everything on one slide makes no sense. You get it?
Yes, sir.
The idea is to convey your thoughts to the examiner. If you fail in that, then your purpose is not being served.
So, sorry, sir.
Right? Okay. So summarize your history now.
So the history is suggestive of a breast tumor, a rapidly growing breast tumor that has progressed over the last 3 months, and it is not associated.
No, what is the size? What is the initial size?
Wait. Don't be in a big rush. Am I audible?
Yes, ma'am.
Yeah, please.
Yeah. So don't be in a big rush. Don't rush through. So you said there is a history of rapidly progressing lump in the breast, right?
Yes, ma'am.
For 3 months. So what is your interpretation from that?
Ma'am, it could be
What do you interpret from it? What are the breast lumps that can rapidly increase in size?
Ma'am, phyllodes tumor and breast carcinoma and also fibroadenomas can also present with rapidly increase in size.
Right. So at this point of time, you're keeping your mind open that it could be a benign or a malignant lump. So
Yes.
can you now name some benign lumps that rapidly increase in size?
Ma'am, fibroadenoma and benign phyllodes tumor and fibroadenosis can also be of rapidly increasing size. It's also a benign tumor.
So when you said rapid increase in size, what we are not able to make out is what was the initial size and to what size did it grow?
Yes,
And
ma'am.
where exactly in the breast did the patient notice it? So there are some things that are grossly missing in the history. Or did I miss them?
Okay, ma'am.
Hello?
Yes,
Yeah.
ma'am. Yes, ma'am.
What was the size to begin with and roughly where did it start?
Okay, ma'am. Ma'am, initially it was a very small lump, size of a grape, and then it progressed over the last
So
6
we
weeks.
expect you to say that as described by the patient, it was as many centimeters and progressed to as many centimeters, right?
Yes,
Now,
ma'am.
did this lump ever decrease in size?
No, ma'am, not according to the patient, ma'am.
Sorry?
Not according to the patient, ma'am. According to the patient history.
So what is the importance of asking whether it ever decreased in size or not? So
Sorry.
inflammatory masses may decrease in size,
Yes, ma'am.
right? While malignant lumps will progressively increase in size only without their decreasing in size ever in between, right?
Okay. Yes, ma'am.
Yeah. Okay. Any other? Now tell us the lump associated changes that the patient may have noticed.
Ma'am, skin changes. Patient may have observed nipple discharge or skin dimpling or puckering, but it was not
So
observed.
what is a clinically suspicious nipple discharge?
Ma'am, bloody discharge. We can see if it is a malignant growth, we can expect a bloody discharge from the nipple.
Tell us the criteria for calling a nipple discharge as clinically suspicious of malignancy. Hello?
Yes, ma'am.
Yeah. So if it is unilateral from a single duct, serous or bloody and spontaneous, right?
Yes,
Yeah. So I would request the other examiners to take over, please.
Okay. And now, Piyush,
yes, ma'am.
Do you ask the patient from where exactly, which part of the breast it started? Is that important?
Uh, mm,
So what tumors or lumps arise from which quadrant? Is that important or not?
yes, ma'am, it is important.
Okay, so what comes from where? Arises from where?
Ma'am, breast carcinoma most commonly arises from the upper outer quadrant of the breast, and
Okay.
the papillomas arise around the periareolar region.
That's all.
Mhm. Phyllodes also.
So you never told from this is a huge one, is it?
So,
This is like a huge lump.
yes, ma'am. To
Okay.
begin with, it was
So you
small.
never told where it started and whether it is occupying the whole breast.
So,
Is that important?
yes, ma'am, it is important.
Yeah, we should have an idea of what you're talking about.
Yes, ma'am.
And then you were talking about discharge. Discharge from where? Did the lump rupture and then it was discharging, just like your abscess or something, or inflammatory swelling?
Yes, ma'am.
Or are you talking about the nipple discharge?
I was talking about the nipple discharge, ma'am.
So how will I know? You never mentioned the word nipple discharge. You
Yes, ma'am.
just said no discharge.
Yes, ma'am.
Yes?
Yes, ma'am.
Yeah, you were so soft and you were not very audible, as I told you earlier, and I am not able to see your PowerPoint also. Just like my examination, I'm just listening intently to what you're saying.
Sorry, ma'am.
Babita, you?
Yes, ma'am.
Yes, something.
Dr. Piyush,
Yes,
you
ma'am.
told that lump is rapidly progressive.
Yes, ma'am.
How exactly? What do you mean by rapidly progressive?
Ma'am, it was increasing in size according to the patient. It was increasing in size over the last 6 weeks. As compared to the earlier 6 weeks, it was rapidly progressing in the last 6 weeks.
What is the normal doubling time in case of cancer breast?
I'm sorry, ma'am, I don't know, ma'am. I'll read about it.
Okay. At least tell me the difference between Babita. Continue.
What is doubling time first? Tell me.
Ma'am,
Then you can tell about cancer risk.
so the time taken by
Then
the
what
She
Ratna
is
madam?
answering. Okay.
Yeah.
so the time
Ratna
taken by
madam asked, when do you call it as malignancy? Remember 3 S: single duct, serous, spontaneous, discharge. Okay.
Yes, sir.
That is one. Now answer, what is doubling time and what is the tumor doubling time in breast?
So the
If
time
you
taken
don't
by
know, just say you don't know.
I don't know, ma'am. I don't know.
We needn't waste our time.
You have to read that one. Very good. Okay.
Okay.
Please.
Yes, so please hurriedly tell everybody what history have you taken with respect to risk assessment in this patient.
Madam, the PowerPoint is not clear, madam.
Yeah, nothing.
What is this actually? What type of presentation is it?
Sir,
It's not
It's
even
not PowerPoint
it is not
presentation.
even the PDF also.
sir, keynote, sir. It is keynote that I've used.
Okay, sir. We'll have to adjust by whatever he
Yeah.
talks. We'll have to grasp and then.
Kindly, Piyush, when you're doing it in the national forum, make it proper, okay?
What history have you taken with respect to risk assessment?
Ma'am, I've taken the history for any family history for breast cancer. In the personal history, I've taken history for any associated risk factors like smoking or OCP intake. And I've also
Let's come to the more relevant ones first. Is she premenopausal, postmenopausal?
postmenopausal.
So how is it important?
Ma'am, because ma'am,
What was the age at menarche?
ma'am, 48.
And age at menarche and age at...
Menarche, she said.
Menarche was ma'am 16, ma'am. 16 was
So
the
you need to talk about some relevant things when it relates to a breast lump. So age at menarche, age at menopause, age at first live birth, parity, right?
Yes,
any
ma'am.
biopsy taken in the past. So all these add to any history of intake of hormones for any reason,
So,
right? Besides family history of cancer breast. So all these things you must pay a special focus and highlight to the examiner that you have assessed risk in the history also for her. And then there are other factors which are modifiable. What are they? You said history of intake of nicotine.
yes, ma'am.
Anything else?
Ma'am, OCPs are also risk factor.
Sorry?
Ma'am, oral contraceptive pills.
No, that has been shown to have, because it has very little amount of estrogen in it. Yeah. Anything else? So even excessive overweight patients are more likely to develop malignancies.
Yes, ma'am. Yes, ma'am.
Yeah. And exercise has also been correlated. People who do less exercise have been found are more prone to developing cancer.
Okay,
Yeah. What about the drug history?
Ma'am, she has only history of taking lisinopril, and there are certain drugs that can increase the risk of breast cancers.
Like?
Ma'am, ketoconazole is known to increase the risk.
Sorry, which one?
Ketoconazole.
Oh.
Ketoconazole.
I actually am not aware of it. Thank you for telling me. Does anyone know about it? We'll have to, at least I'll have to see. Anything else? So drug history is also important because there are some drugs that may cause nipple discharge.
Okay, ma'am.
And thereafter lead to, yeah.
Okay.
So any correlation between diabetes and a breast lump?
Yes, ma'am. Diabetes also increases the risk for breast carcinoma, ma'am.
No, it doesn't increase. There is a condition which is called diabetic mastopathy, which may lead to the formation of a lump and may mimic malignancies. But diabetes does not increase the risk. Please don't cook up answers, no, because it makes us feel that we need to read more, right?
Sorry.
Yeah. Please carry on with the history.
Okay. Now, Piyush,
Yes, ma'am.
you said this is rapidly increasing.
Yes, ma'am.
Yes.
Yes,
So
ma'am.
what is gradual increase? Which one increases gradually? What is sudden increase? And what is this rapid increase? Is there any difference between all the three? Gradual, sudden, and rapid. Or you want to differentiate between sudden and rapid?
Ma'am, ma'am, inflammatory.
So gradual is, slowly growing. Yes.
Yes, ma'am.
So that will be benign or malignant?
That will be benign, ma'am.
That's going to be
Yes,
benign.
ma'am.
What about your rapid growing?
Ma'am, rapid growing can be seen in traumatic and inflammatory lumps.
Rapid growing and dramatic. Trauma happens only once, not daily. So rapid is again malignancy, suggestive of malignancy. What is sudden then? Sudden changes occur in the swelling, okay? Like bleeding into the swelling.
Yes, ma'am.
Yes? Or there is an injury and suddenly it develops. That is your trauma. Sudden. Okay? So that's the difference between a gradual, sudden, and rapid. So your swelling here is which one? Rapidly increasing, right?
Yes, ma'am.
There are some swellings, your benign swellings that can become rapid also.
Yes, ma'am.
Just like your case, right?
Yes, ma'am.
Benign ones becoming rapid. Still, we don't know whether it is. We are talking about benign or malignant phyllodes, right?
Yes, ma'am.
Yes or no?
Yes, ma'am.
Yes, but it is a phyllodes.
Not based on history, ma'am.
Okay, not based on the history, you don't know. But you only know that it is a rapid increase in size without any skin changes, without any nipple discharge.
Yes, ma'am.
Yes?
Yes, ma'am.
No pain also.
No pain, ma'am.
Okay.
So did you tell us if this was the only lump or did she notice any other lump also anywhere?
Ma'am, this was the only lump she observed.
No, you're saying that, but did you mention it in the history?
No, ma'am, I did not. Sorry, ma'am.
Sorry?
Sorry, ma'am, I did not mention it, ma'am.
this must be mentioned, that this is the only lump that she's noticed now also in this breast, and that she's not noticed any other lump in the opposite breast also or in the axilla.
Okay.
Did you mention about pain? No.
Ma'am, I mentioned about the pain, ma'am. It is a painless.
Painless.
Yes, ma'am.
Does she have pain or not?
No, ma'am, she does not have pain.
No. Okay. 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 Continue then.
All these questions are being. She's very.
Sorry, sir.
All these questions are being asked because your history is very haphazard. Your history
How
should
old
be.
is she?
So, ma'am, 55-year-old.
55 years.
Yes, ma'am.
55 years.
Yes, ma'am, 55.
Okay. Now, what is your diagnosis? Can you tell me?
Ma'am, it is.
Sagai sir, you're not audible. Sagai sir is telling something. He's not audible.
Okay. Anyway, let him talk. So, shall we go to, if there is nothing relevant in the history, shall we go to examination then?
Yeah, please proceed.
Anyone else?
Yes, ma'am.
I just wanted to ask something. May I?
Yes, ma'am. Sure.
He said about no other first degree relatives, breast or ovarian cancer. Piyush, would you like to expand on this?
Ma'am, ma'am, there are certain
It's
syndromes.
only breast or ovarian, or if you are
Anything
going
else?
into
Ma'am,
risk
also.
management, would you like to ask more?
Yes, ma'am. We'd also like to ask about the colon and pancreatic cancers, because certain syndromes are associated with the this syndromic presentations of different cancers in different relatives in these syndromes, like HNPCC and
Anything which can also come as breast cancer in a female?
ma'am, ovarian mets can also present with
And
mm,
parent, any other parent having any other disease? I'm giving you hints.
ma'am, testicular cancer then can also
Can come as testicular cancer.
no, ma'am,
Which other cancer is related with BRCA?
Ma'am, pancreatic cancer, prostate cancer, and
yeah, prostate.
yes, ma'am.
Okay. Okay, go ahead.
Past history, is there anything significant? Are you supposed to ask about past history? Piyush?
History of smoking, ma'am.
Past history. Did you ask for any similar lumps earlier, lump breast earlier?
No, yes, ma'am. I did not mention, ma'am. I did ask, ma'am.
Forgot to mention. Okay, so you're not all that audible. The slides are not very well seen. Okay. Anyway, anyone else wants to add upon?
Madam, is the history of multiple abortions important? I'm asking the forum. Students should have.
Yes,
Ratna, madam, you can answer, please. History of multiple abortions.
Yes,
Sir, the patient might have maybe some hormone issues.
But is it related to breast cancer?
No, suppose we are going to talk about obstetric history, they can always mention. Then we can conclude that the patient would have had any hormonal issues then. Being a gynecologist also, this is what I can say.
Does it increase the risk of breast cancer or not?
Sir, when there is hormonal imbalance, some estrogens.
Okay, madam. Thank you.
Yes, Piyush?
Yes, ma'am.
Go to general examination then.
General examination, the patient was alert, conscious, and in no acute distress. The patient was vitally stable, and on the examination of the right breast.
Vitally stable. Okay. Vitals were stable.
Yes, ma'am. On the examination of the right breast, there was a large, firm, mobile, well-circumcised mass in the right upper quadrant. It was 8 into 6.
No. General examination is over.
Yes, ma'am.
What did you tell about general examination?
One patient was alert, conscious, and in no acute distress, and the vitals were stable. There were no signs of any systemic distress to the patient.
So you never said anything about her build. Is build important in the case of breast malignancies?
Yes, ma'am. Yes, ma'am. Very good.
Ah, then why don't you mention about the build? Just now, Ratna ma'am said about obesity, right?
Yes, ma'am.
Then, so you are supposed to mention about the BMI or the build
Yes,
in
ma'am.
the case, especially in the case of
Breast cancer.
breast lumps, right?
So what
Okay,
are some
continue.
findings that you may find in
Hmm.
general physical examination in syndromal malignancies of breast?
Ma'am,
So, breast may present as a syndromal malignancy also
yes, ma'am.
with other malignancies. So, can you find anything in general physical examination?
Ma'am, we can see skin changes in the palms. Of
So,
the
you may find syndactyly or polydactyly only from any. You may find, what is it called? White patches in Cowden syndrome,
Yes, ma'am.
right?
Yes, ma'am.
So, yeah, and you must talk about the performance status of the patient since you are keeping malignancy in mind. Which performance status would you want to talk about if you are thinking of malignancy?
Ma'am, Karnofsky's performance status, ma'am.
So, Karnofsky's is usually talked of in benign cases. I mean, in non-oncological cases, you may consider speaking about the ECOG score,
Okay.
right? Yeah. Okay, proceed to regional examination.
Ma'am, there was on examination of the right breast, there was a large, firm, mobile, well circumcised mass.
Why you don't examine bilateral breast for symmetry and all that? You don't look
Yes, ma'am, look.
the position of the patient.
So the patient was examined
Yeah.
sitting
Hmm.
position with after taking consent, and the patient was exposed
Where
from
were the arms?
the arms were by the side. First, it was by the
Hmm.
side. Then we asked the patient to raise up both her arms, and then we placed the arms on her waist. We examined these three positions, ma'am.
We examined or I examined?
I examined. Sorry.
Okay. Hmm.
And on the examination of the left breast, the left breast was normal. There was the nipple was normal. There was no retraction, and the skin
No,
over
breast,
Now you
breast
are in
symmetrical or
inspection,
not?
no?
Hmm. Symmetrical or not?
Inspection, you start arms
Well-
by the side. You start with what is the symmetry of the breast, level of the
Hmm.
nipple. Are you able to see any fullness? You go by systematically.
Hmm.
An examination, no?
Yes, ma'am. Yes, ma'am. Ma'am, the breast was there was fullness in the right breast, outer quadrant, and the nipples were at the level at the same level. And on further examination, there was a large, firm, mobile, well circumcised mass in the right upper quadrant of the.
No. Inspection, arms by the side, arms raised above the head.
Yes, ma'am. And on
Ah.
placing the arms.
Go by step. And what is the nipple areola complex? Are you able to see any other pudgy orange or skin over the breast? And what about any
Changes in the
nodules
skin.
over the chest wall? What about the supraclavicular? What about you go by in the
Axilla.
stepwise manner.
Ma'am, on placing the arms by the side, we inspected the patient. Both the nipples were at the same level, but there was fullness in the right upper outer quadrant, and there were no skin changes, no purely orange changes. There was no dimpling and puckering of the skin. The nipple was not retracted, and on raising the arms by the above the head of the patient, there was no puckering or dimpling in the axilla as well, and then we proceed to the local examination.
What about the inframammary area?
The inframammary area was
Are
also.
you able to see any nipple retraction or nipple pulling of the nipple towards the lump?
No,
Or
ma'am,
whether the lump becomes more prominent?
the lump did not become more prominent on raising the arms, and there was no retraction of the nipple. Uh, and the inframammary area was also visible on raising the arms. It was unremarkable.
It will be visible. How was it? It is normal, or are you able to find anything significant in the inframammary region?
Did you tell about the size of the lump?
Ma'am, it was 18 to 6 centimeters on palpation.
On palpation, no inspection.
Inspection, ma'am, there was fullness of the right upper quadrant, roughly
Just a fullness, nothing else. Fullness
5 to
was occupying what quadrant then?
right upper quadrant, ma'am. Outer, right upper outer.
That's all. You said large and then right upper quadrant only. Upper outer.
Um,
Do you have a picture?
It is good to express it as from as this much o'clock position to this o'clock position,
okay.
and as from the nipple, or is it occupying the retroareolar area also? So distance from the nipple and the clockwise position of the lump is a good way to describe the lump.
Yeah. It was,
Do you have a picture of it?
actually, I took the case in the post-op period, ma'am. I did not have a pre-op photograph, and the patient did not consent for the pre-op photograph before the surgery.
Okay. Now you never mention about the size. You never mention about the surface. Whether you didn't mention whether it is well defined or ill defined.
So I was coming to that.
You didn't
ma'am.
tell me about the skin changes, whether it is seen or not.
Sorry, ma'am. I was just coming to it, ma'am, in the local examination.
In inspection.
Yes, ma'am.
I thought you were about to finish.
Ma'am, on inspection,
Okay.
the lump was mobile, the surface was smooth, the consistency was firm.
Lump was mobile. This is inspection or palpation.
Palpation, ma'am.
I'm talking about inspection. I'm still in inspection. So you'll have to tell me where the lump is. You just said fullness.
Yes, ma'am.
You're not able to see a lump. What about the surface of the fullness? Fullness is smooth?
Yes, ma'am. It was
Okay, fullness is supposed to be smooth. It is well defined or ill defined. Fullness means again ill defined.
Yes, ma'am.
Okay, so what happens to this fullness when the arms are raised up? Does it become a lump? Is a lump seen then? Does it become a little more prominent, become a lump?
Ma'am, it becomes a little bit more prominent, ma'am, but
More prominent. That you should tell us.
yes, ma'am.
He said, I think
Okay, then are you able to mention the dimension?
he saw the patient
Dimension at
only in
least
the
then.
post-operative period. He
Oh.
saw the patient in the post-operative period. I
How
heard
then
him
he is
say,
cooking?
I heard him saying that he saw the patient only in the post-operative period. So all your questions,
Oh my God. No, I thought he has got a picture, sir. I thought he's got a picture of post-op.
He cannot answer.
Okay, okay.
You told
So
like that only,
how are we
no?
going to? No, I thought he has got a picture of the post-op period only.
Piyush, what is it? You saw the patient pre-operatively?
So I saw the patient pre-operatively, sir, but
Then answer madam's questions. I
yes, sir.
thought you saw only in the post-operative.
So, ma'am, the fullness became more prominent on raising the arm.
More prominent, then you'll have to tell us the dimension.
It was roughly 5 to 5 centimeters of fullness in the right upper quadrant.
Then you said huge one or something, no?
So,
In palpation, it is huge, not in inspection.
yes, ma'am.
Okay. Okay, then. So when the patient lifted up the arms, you were able to see the axilla. There was nothing in the axilla. No lumps seen. No
Yes.
swelling seen.
Yes, ma'am.
Okay. Again, supraclavicular fossa, as ma'am said, nothing there.
Yes, ma'am.
No fullness.
Yes,
Okay, now go to palpation.
Ma'am, a large, firm, mobile, well circumcised mass was palpated in the right upper quadrant, upper outer quadrant of the
If
right
you
breast.
say large, I don't know what is large to me will be small to you. You're saying large and then you're talking about 5 into 5. Then don't mention as large.
Okay, I'm sorry.
Okay? Yes.
It was 18 to 6 centimeters in size, and it was firm in consistency, mobile, smooth.
No, warmth, tenderness. Did you start from there?
Yes, ma'am. There was no warmth, no tenderness, no skin changes in palpation, and the margins were the mass was
No,
18.
size, shape, surface. It goes like that, no? Just go in that order.
It was in the right outer upper quadrant of the right breast, and it was 18 to 6 centimeters in the size. It was so globular in shape, and it was extending from the 9 o'clock to the 12 o'clock position. The margins were well circumcised and the surface was smooth, ma'am.
Have you got your
Margin or border?
Ma'am, on the border of the swelling, ma'am, sorry.
Okay.
examination?
The overlying skin was tense but intact. There were prominent superficial veins present. The nipple was not retracted and there was no discharge. On the examination of the lymph nodes, there were no axillary lymph nodes palpable. There were no supraclavicular.
No, how was the skin?
The skin was normal, ma'am. There were no skin.
Normal. It was not thin and stretched out and all.
It was tense, ma'am. It was tense on the right upper quadrant, ma'am.
Okay. It was stretched out.
So in the right upper quadrant, ma'am.
Okay. Then what about the skin changes? Any skin changes?
There was no skin changes,
The
ma'am.
skin had stretched out then?
There was just prominent
No
superficial.
nodules? No ulcers?
No ulceration, ma'am.
No purity orange?
No purity orange, no puckering.
Dilated veins were seen?
Yes, ma'am. Dilated veins were present. Dilated superficial veins.
Okay. Dilated veins or prominent veins?
Ma'am, prominent superficial veins, ma'am.
Okay.
The skin was pinchable.
Ma'am, the skin was pinchable, yes, ma'am.
What was the mobility of the swelling?
Yes, ma'am.
Lump?
The lump was mobile below the skin. It was mobile and it was not adherent to the skin, ma'am. The skin was pinchable.
Now, what about
Okay.
around the
Mobility is not to the skin,
it is to the breast tissue.
to the underlying one. So what is the underlying one?
Ma'am, it was not adherent to the underlying chest wall and also to the surrounding breast tissue as well.
So what is the underlying one? What is this underlying the breast lump?
Breast carcinoma. Breast carcinoma is usually adherent to the skin, ma'am, and also adherent to the surrounding.
We are not talking about the skin. You said skin is free.
Yes, ma'am.
Now you said underlying. So what is that underlying this lump?
Ma'am, underlying breast tissue and chest wall, ma'am. Pectoralis muscle.
Chest wall.
Pectoralis muscle, ma'am.
Pectoralis muscle and fascia.
This one.
Sir, you are not audible clearly, sir. Sahai, sir.
Yeah, I was saying, could ask Fisher's examination, you already asking questions. Okay, let me get to another device.
Piyush,
Yes, ma'am.
during palpation, could you move the lump in other quadrants also?
Ma'am, it was not possible to move to the other quadrants, but it was mobile horizontally and vertically, ma'am.
Okay.
No, you should tell whether the movement with the independent of the breast tissue or it moves along with the breast tissue.
Okay, ma'am.
What is your finding?
Ma'am, it was moving along the breast tissue. Then, ma'am, it was moving horizontally and vertically, but it was not moving to the other quadrants.
If you say it doesn't move independent of the breast tissue, then you are ruling out all the benign tumors. Is it so?
Or is it too large that you're not able to elicit this properly, the movement,
Yes, ma'am,
mobility?
I was not able to assess it properly.
Ma'am, may I come in, please? This is Dr. Sahai. Ma'am,
Yes,
could we
yes.
let him please finish his examination and then ask him, because this whole thing is getting very haphazard now. So Piyush, you just finish your examination and then the questions will be asked.
So on
Right.
clinical impression, there was a unilateral right breast mass and with well-defined borders, and there was no skin involvement and no lymphadenopathy. The surface was smooth and the lump was mobile. And then we move, like to move to the diagnostic imaging.
Hang on. You can't go into diagnostic imaging just now.
Yes, sir.
Finish your clinical examination.
Yes, sir.
Have you done with it?
Yes,
Sir,
sir.
it is because his clinical examination was very much incomplete, sir. So that only.
And also we are not able to see the this
Exactly.
one, PPT.
Piyush.
That is why we are
Very much
stopping him then and
incomplete,
there.
so that only we were able to interfere him.
We thought we'll correct him then and there.
Piyush.
Okay, sir. Anyway.
Yeah. Okay. You summarize your history and examination, please.
Sir, a 55-year-old postmenopausal female, gravida 3 para 3, came with complaints of a lump in the right breast, which has increased in size over the last 6 weeks. And on examination, I can.
So, Piyush, have you written this out, or are you saying it out of your memory?
Sir, out of my memory, sir, I've not mentioned it.
No, you're supposed to write it out. You can't. You will not be able to summarize your history like this by memory.
Sorry, sir.
Yeah, you have come unprepared for this presentation. Right, ma'am, please take over.
Yes, Piyush. Examination of other system and all that you finished?
So the systemic examination was unremarkable, ma'am. I mentioned in the general examination.
Huh?
Ma'am, I mentioned in
No, that is only for general examination. Pertaining to any system examination, if you are examining the
Babita.
yes,
Piyush,
ma'am. Sorry. Audio was
have you examined the abdomen? Have
Oh.
you examined the chest? Have you examined the back, the spine?
Yes, sir. I have examined, sir. Not mentioned.
This is what is being asked.
Yes, sir.
No, I think Piyush.
Yes, ma'am.
Piyush, you didn't come prepared for presentation like a carcinoma breast. You just wanted to make it like a short case presentation, right? Just the gist of the case and then discussion. Is that so?
Sorry, ma'am.
If that is so, then you go for your diagnosis. We'll go along with you. Just tell us the diagnosis then. Don't funk, man. We are just waiting for your diagnosis.
Differential diagnosis are, first of all, it's Phyllodes tumor of the right side of the breast. And my other differentials are fibroadenoma. And it might be a giant fibroadenoma, and it can be.
Piyush, how can you decide it's the phyllodes just by examination?
So the history of a single swelling, which is gradually, which has increased in size over time, and the margins are regularly.
How by examination can you arrive at this diagnosis? It's a pathological diagnosis.
Yes, sir. Yes, sir.
So how can you say that is my diagnosis is Phyllodes tumor?
Sorry, sir.
Ma'am, please.
So what makes you call this as phyllodes are not a malignancy? I agree. You're sure it's not a CA breast?
Ma'am, this CA breast patient, ma'am, would present with weight loss and also
Weight loss.
anorexia and weight loss might be there, and also
CA
No,
breast
that is
patient.
the very
That is the last thing you say.
Patient will also have the lump will be adhered to the skin, and there might be skin changes.
Okay, Piyush, let me ask you, what is the surest sign of a malignant condition? How can you be 100% sure that this tumor is malignant? Just by examination.
So signs also.
It is a mobile swelling lump.
Yeah, metastasis.
Yes, sir.
The surest sign that is malignancy.
Yes, sir.
Right?
Yes, sir.
Now, do you have metastasis in this patient?
Sir, on history and examination, I cannot. I don't, sir.
Now, the second would be, are the lymph nodes involved?
So lymph nodes were not palpable, sir. Lymph nodes were not palpable.
Okay. Now, third is there local infiltration into the surroundings?
Yes, so there was no local infiltration around in the skin or to the surrounding regions.
So your the lump is not malignant.
Yes.
Clinically.
Yes, sir.
But you can't say it's phyllodes.
Yes, sir. Sorry, sir.
Right. Ma'am. Ma'am, please take over.
Yeah. So you said phyllodes, right?
Yes, ma'am.
And I'm saying this fibroadenoma.
Yes, ma'am.
Yeah, tell me. How do you say this is phyllodes and not fibroadenoma?
We can proceed with the core needle biopsy. for the tumor, and
Now, clinically,
clinically, the age of the patient is more fibroadenoma is more common in younger patients.
so what is the age of the patient now?
55.
55.
Yes, ma'am.
What is the age at which fibroadenoma occurs or phylloids occurs? Any one age you tell me.
20 to 30 years is a more common age for fibroadenoma, and 30 to 40 or above 40 is more common for phylloids.
Okay, 40 to 50 will be for your phylloids, right?
Yes, ma'am.
Okay, continue. So the skin is free here and the lump is also mobile.
Yes, ma'am.
And if the fibroadenoma is more than 5 centimeters, what do you call it?
We call it giant fibroadenoma.
A giant fibroadenoma. Can a fibroadenoma become, what is that, phylloids later on?
Yes, ma'am. It can become.
It can.
Yes, ma'am.
Yes? Okay, now how do you want to confirm? Babita,
We can.
Ma'am,
anything
I
else?
have one small question. You have
Yes.
written differential diagnosis breast sarcoma.
Yes.
Your differential diagnosis should be, if it is a benign condition, it should be DD of the all the benign condition. You cannot put a benign and malignant as a DD.
Okay, ma'am.
A sarcoma is a malignancy, no?
Yes, ma'am. Sorry,
Mm.
ma'am.
As sir told, now there is no local infiltration, no lymph node, no metastasis. Then you
Yes.
have been ruling out all malignancies. So your DD should be like
Yes, ma'am.
phylloids or giant fibroadenoma.
No, but you're saying yes for everything, no? That means the patient will not need any investigation. Would you want to keep an option of malignancy or not?
Ma'am, I would like to do a core needle biopsy.
Yeah, but clinically, on the basis of clinical examination, would you want to keep an option of malignancy or no option for malignancy?
I would like to keep an option for malignancy before I
You would
do.
want to keep it lower down in the list, but surely, as ma'am said, that you cannot keep it as an important differential diagnosis.
Yeah.
What happens to the nipple areola complex in benign conditions?
Ma'am, if it is mostly not involved, ma'am, in benign conditions, it is like the nipple retraction and
So the nipple may become more prominent because the lump may push it forwards, right? It may be deviated away from the lump,
okay.
right? And then the areola may get widened if the lump is in the retroareolar position.
Okay.
Yes, that's what Madam was asking all the questions. See, the classical phylloids, usually the breast on the affected side will be huge. It's larger than the opposite side. Number one. Number two, the surface will be bosselated. Number three, variable in consistency. Number four,
I think you never mentioned about the consistency, sir.
dilated veins. Now, let me finish, madam. Dilated veins, prominent veins may be seen. There will not be any skin changes. The nipple areolar complex will be pushed to the same opposite side. Because it's a benign condition, it is just pushing, it will not infiltrate the nipple area complex. And the last but not the least is absence of lymph nodes. Such a huge breast, if it is malignancy, it will be pulled up, but here it will be hanging down. So large breast, bosselated surface, variable in consistency, no skin changes, dilated veins, absence of lymph nodes. If you would have told these points which were there, we will consider it as phylloids straight away. Okay.
Yes.
Okay, carry on, please, madam. You didn't say that's what you asked about the surface.
So you never said about the surface, you never said about the consistency.
That's all right, Piyush, we corrected, okay. These all we think.
Okay, anyway, sir, we'll ask him to go to investigations.
It's a platform to learn, Piyush, so you correct yourself.
Yes.
No problem. Keep going.
No. Suppose we like to do an ultrasound and a mammography for the patient. On the mammography, there was a large, well circumcised, dense mass measuring.
No, please don't read it out. No, that's not a good way to present. I think you can stop your presentation to the clinical diagnosis. Now you tell us, how will you manage this case?
Ma'am, first of all, I would like to do a ultrasonography of the breast,
So
and
phrase your answer in a better way.
ma'am, I would like to proceed with a ultrasonography and a
So
mammography.
you may want to proceed with triple assessment in this patient. Clinical examination has been completed. Yeah.
And for the triple assessment, we'll do a ultrasonography and a mammography, and then core needle biopsy for the FNA or biopsy for the patient.
Again, phrase it better. You would want to do an ultrasound guided core needle biopsy or a direct core needle biopsy. It's a large lump.
So, and
No, this is not the answer. No, what would you want to do?
ma'am, I would like to do a USG guided core needle biopsy for the patient.
Yeah, why should it be ultrasound guided?
Ma'am, it is more accurate if it is ultrasound guided than.
What do you mean by accurate? So sampling error is less and you will hit a solid area only if the lump is variable in consistency. Right? Yeah.
And based on the findings of the biopsy and
Would you want to do the imaging first or the biopsy first?
ma'am, the imaging first, ma'am.
Right.
I would like to rule out any even if it is a low possibility, I would rule out a malignancy uh, or any other secondary lesions that might have I've missed on
It will
the.
tell you about the nature of lump that you are dealing with and the exact pathology. Yeah. Would FNAC suffice?
Ma'am, FNAC is not sufficient at times, so I would like to proceed with the true cut biopsy.
Why is it not sufficient?
Because it is low on accuracy. We can easily miss.
No, but that is not right. That's not correct.
No, it is not.
Why not FNAC? So it does not tell you about the status. It may show you malignant cells, but it does not tell you whether it is an infiltrating malignancy or not.
Okay.
Right? Yeah. And then core needle biopsy gives you more tissue for molecular
studies
evaluation also. Yes.
Yes.
Yeah. Then what else will you do?
Ma'am, after my triple assessment,
Why do you want both in ultrasound as well as mammography?
Ma'am, to look for calcifications if microcalcifications and macrocalcifications.
You can see them on ultrasound also. So isoechoic lumps may not be very clearly seen on ultrasound.
Okay.
If they have the same echogenicity as the breast parenchyma, they may not be very well seen, though they are clearly palpable. Right? Yeah.
Okay.
What are the mammographic findings suggestive of malignancy?
Well, mammography findings were not suggestive of malignancy.
No, you tell us. Forget about what you found in this game. We want you to tell us what are those mammographic findings which are suggestive of a malignancy.
We get speculated margins on mammography malignancy, and we get lymph node. We can also see lymph nodes which are.
No, what madam is asking is what are
Tell
the
about the lump
mammographic
first.
Irregular.
can say in cases of malignancy.
The lump is hyperechoic, and most of the times, and
Mammography, you don't talk about echogenicity, no? You talk about
lucency. Lucency, we talk about
you talk about the parenchymal density. It's a high density lesion that you see. In CT, you talk about
Margins are regular, is that, Piyush?
No, margins are irregular in malignancy.
Then tell all that.
Yes, margins are irregular in malignancy and mostly speculated margins. And
you can see some changes within the lump and some changes.
This one we can also see
outside the lump also. You may find parenchymal distortion outside the area of lump. You may find other features of carcinoma in situ like speckled calcification.
Okay.
Right, clustered microcalcification, actually, not spectral. Then you may also find some skin changes if they show any features of what irregularity in the form of either skin fixity also can be visualized on mammography
Mm.
as a change in the outline of the skin and decrease in the subcutaneous tissue.
Okay.
Even nipple changes can be
No.
visualized on parenchyma. So you have to see the whole mammogram film, not just the lump.
Okay.
Yeah. So you've done
And
that.
then you talk about the lymph nodes.
Yeah.
Mm.
Can somebody give him the findings of? Okay, you tell us, what did you find on the core needle biopsy and mammography?
It was a mixed tumor of stromal and epithelial cells on the core needle biopsy, and which was suggestive of a Phyllodes tumor. They were dispersed stromal cells, and there was also cellular polymorphism and hypercellularity and aberrant mitosis on the examination of the biopsy, ma'am, pathological biopsy.
Yeah. So why is this stromal hypercellularity? What is the etiopathogenesis for that?
Because of
Can you please change the slide where you showed that
showed what, ma'am?
the mic? Yes.
Yes, ma'am.
No, please answer.
Ma'am, it is due to the hormonal disbalance, ma'am. The stromal proliferation happens, and that is
So which hormone leads to more proliferation of stroma?
ma'am, progesterone leads to more proliferation of the stroma, ma'am.
So you mean to say it is hyperestrogenism which is leading to the development of phyllodes?
Uh,
So it's probably there are changes that happen in the ductal cells that trigger a change in the stroma. Right? It's also supposed to have a genetic basis behind it.
okay,
That
ma'am.
alteration in the genetic profile leads to this. So, what are the various ways by which you can histopathologically classify Phyllodes tumor?
Ma'am, we can classify the tumor into benign, borderline, and malignant.
Can you tell us the histopathological criteria for that?
Ma'am, we use four parameters: the tumor margin, the stromal cellularity, the mitotic rate, and the pleomorphism, ma'am, of the biopsy.
Yeah. So, which out of these is majorly used for?
Mitotic rate, mitotic index is,
Mitotic figures, right?
yes.
Not mitotic rate. Mitotic figures, how many?
Ma'am, if it is less than 5, it is a benign. It is suggestive of a benign tumor, and if it is 5 to 9, it is borderline, and if it is more than 9, it is malignant, ma'am.
So, how does it matter whether it is benign or borderline?
On management changes, ma'am, with the and also the patient outcome and the recurrence rate changes with the grade of the Phyllodes tumor. If it is a benign or borderline tumor, we like to go for wide local excision, or if it is a malignant tumor, we like to go for mastectomy, and we'd also like to give patient radiotherapy and chemotherapy post operatively if it is suggestive of a malignant tumor.
So, you don't have the image. Why are you so dogmatic about the fact that if it turns out to be malignancy, the option is going to be only mastectomy?
Ma'am, we can also do wide local excision.
So, no, you need to go slow. For benign, you can say whatever. You said the management is wide local excision, no?
Yes, ma'am.
Right? And then in cases of malignancy, you would want to stage the disease like you would want to do in any case.
Yes, ma'am.
And then thereafter take a call. Yeah. Can you consider malignant Phyllodes tumor for for a benign breast conservation surgery?
Uh, excuse me. Ma'am, I'm not sure, ma'am, but I don't think we should.
Why?
Because
Soft tissue sarcoma of the limb or anywhere in the body you consider wide local excision. Why is it that in the breast you want to do mastectomy only? Everywhere, head to toe in the body, you do wide local excision. Hmm.
Sorry, ma'am, I don't know.
Yeah. So you should give the option of management to the patient, tell them about the chances of recurrence, take them in the loop, and then I leave it open to others. Would anybody want to say any other opinion on this? Is mastectomy the only answer for a malignant Phyllodes?
No, madam.
So Binay,
It is the first
you
when
need to
you
see
said
the
it for
size, the
malignancy,
tumor
you have to
breast
do
ratio.
a wide
So,
local excision.
yeah.
The
Yes.
margin of clearance is very much important.
Yeah.
So,
So if you are able to give more than 1 centimeter of margin of clearance, then wide local excision is ideal. If you are going for a recurrent malignancy, then you can do mastectomy. Even mastectomy, what type of mastectomy do you want to do?
we can go for a simple mastectomy, ma'am. We're doing it for
Why?
because the axillary dissection is usually not advised for these patients because
Not
these
advised. Why?
because these tumor they hardly metastasize to the lymph node. If it even if it is a malignant phyllodes, they usually metastasize by hematogenous spread. And uh, if it is if the axillary nodes are involved, we can do selective lymphadenectomy. But the
No,
tumor.
it's actually it is very rare only. Axillary nodal metastasis is very rare.
Yes, ma'am.
Do you think this, if it is a benign phyllodes, can it recur?
Yes, ma'am. They have a very high chance of recurrence.
Did he talk about grading first of all?
Yes, ma'am. They classify into 3 grades: one benign, borderline, and malignant, ma'am.
Okay, so that is depending on what? Half
Ma'am,
of it was discussed earlier, but you never mentioned about this. That is why.
ma'am,
Babita, is it okay?
Yeah,
He finished that, madam.
he
Yes,
talked
ma'am.
about
Yes,
You
told
ma'am.
about-
mentioned, is that okay?
Yeah.
Okay, okay.
He told
I
about
missed
ND.
it then.
He answered,
Okay,
madam,
okay, okay.
about
Okay,
mitotic
okay
activity
then.
and everything.
Now, depending on what it is, how will you manage?
ma'am, if
Benign, borderline, and malignant. Benign, how will you manage? Borderline, what is the management? And will that help you in any way?
ma'am, for
I'm giving
benign,
you some clue for management discussion.
ma'am, for the benign tumor, we'll take up the patient for wide local excision. We'll
Okay.
we'll like to ensure a 1 centimeter margin, more than 1 centimeter margin for the tumor, and post-operatively.
Babita has answered you now?
Yes, ma'am.
Yeah.
Ma'am, for the borderline
Page
tumor,
can continue.
for the borderline tumors, we'll also take the patient for wide local excision, and post-operatively, we can think of giving the radiotherapy and the chemotherapy to the patient if it is a borderline case. For malignant tumors, we will do a proper workup for the malignancy and staging, and then we'll plan.
Usually we won't recommend chemotherapy for a phyllodes. It is
Yes.
only the radiotherapy. Only if metastasis only you'll go for a chemotherapy, not for a local disease.
Okay.
Okay. So for all others, the chemotherapy plays a major role, but not here. Okay. So what are the types of mastectomy you want to do? We have done a wide local excision. So you will be very happy, and the patient is also satisfied with your wide local excision. You will ask the patient not to come back to you.
We'll keep the patient on follow-up, ma'am.
Why?
Ma'am, because there's very high chance of recurrence, and
What is the percentage of chance of recurrence?
I'm not sure.
High means how high?
Ma'am, it's 20 to 30%, ma'am. I'm not sure, ma'am, but 20 to 30%.
Okay. So 15 to 25, 10 to 25.
Yeah. And we'll keep the patient on 6 monthly follow-up, ma'am, for 2 years, and after that, we'll.
Did you ask for past history of any lump?
Yes, ma'am.
Do you understand lump breast?
Yes, ma'am.
Okay, because recurrence is very common here.
Yes, ma'am.
Okay.
So what are the technical considerations that you would have along with wide local excision?
I'm sorry, ma'am, I didn't understand.
It's a large lump. You have excised with 1 centimeter margin all around,
Yes, ma'am.
considering it to be a benign Phyllodes tumor.
Yes, ma'am.
Would you want to do anything else other than?
Ma'am,
You want to discuss it with the patient that something else can also be done for her?
For cosmetic reasons, we can also ask the patient to go for, as you have mentioned, BCS, breast conservative surgery, because of the size of the tumor, the contour of the breast might change after surgery, ma'am.
Yeah. So what are the options that you may want to give?
Ma'am, we can give her the option of breast conservative surgery and mastectomy, simple mastectomy, ma'am.
No,
No. Madam is
that has happened.
asking,
She's opted for
he's
breast
not able to
conservation
understand,
surgery.
madam, I think.
So you want to reconstruct also. So
Okay.
what are the options for reconstruction for such patients?
Ma'am, we can use the latissimus dorsi flap.
Straight away.
No,
I
madam
asked
is
you a general
not for
question.
only for BCS. If it is a large tumor, you have done a wide local excision with a 1 centimeter clearance. Will you do anything else to restore the contour of the breast as compared to the opposite?
Ma'am, we can use the silicone implants for the patient.
So you need to see the extent of resection done or the volume removed, and again the tumor breast ratio,
Okay.
right?
Okay, ma'am.
So if more than 20 to 30% volume is removed, you may want to consider.
And implant or
No, not like that. No, they can be either volume replacement or volume displacement, right?
Have you had of oncoplastic surgeries? Oncoplastic breast surgeries.
yes, ma'am.
That's what madam is asking.
Yes, ma'am.
Yeah. So if less than 25% is removed, you can do volume displacement. Can you name some incisions for volume displacement?
Sorry, ma'am. I'll read about it, ma'am. Very sorry.
Yeah. So what are the levels of, you must know about the donut incision, ME batwing incisions, right? Yeah. Wise pattern. Okay. So what are the levels of oncoplasty that you know? See, when you'll get a case of Phyllodes tumor, these are the issues that will be discussed. What are the levels of oncoplasty that you know of?
I'm sorry, I'm not read about the topic, ma'am.
Oh,
Sorry.
yeah.
Okay, then you'll tell me about the incisions, is it? What are all the types of mastectomy?
Ma'am, for this patient, we'll advise a simple mastectomy for the patient, ma'am.
Simple mastectomy means what are you going to remove?
We'll remove the tumor and we'll take a 2 centimeter margin around the tumor.
Tumor?
Yes, ma'am.
Why does it have a
Tumor is
margin if
inside.
it's going to be simple mastectomy?
Ma'am, we'll remove the parenchyma of the right breast along with it, ma'am.
It is just a mastectomy. Yes, what you regularly do without axillary dissection.
And we'll remove the.
When you go do an axillary dissection, what is it called along with mastectomy?
Ma'am, radical mastectomy.
Radical. Modified radical or radical?
Modified radical, sorry. Modified radical.
So, yes, without axillary dissection, it is called a simple mastectomy. Then for phyllodes, if it's going to be a benign one, what mastectomy can you go for? Do you want to remove the nipple areolar complex and all that?
Ma'am, we can preserve the nipple areolar complex, ma'am, in case of phyllodes.
Yes, what is it called? Subcutaneous mastectomy. Then what is the incision?
We take a periareolar incision in the patient.
Submammary incision, what is that called? Galen-Thomas incision. So you just lift it up, go remove the tumor and come back, okay? So you're going to leave the subcutaneous fat there if it's going to be a benign one. How many times can you, suppose there is a recurrence, what will you do?
If there's a recurrence for the surgery after we have done a wide local excision, we'll plan the patient for mastectomy, ma'am.
Okay, even after mastectomy, there is recurrence. What is that? Subcutaneous mastectomy. Then you go for a, twice if there is a recurrence, then you go for simple mastectomy. Not otherwise, you said simple mastectomy first answer, right?
Okay, ma'am. Okay.
Okay, at least twice you go for your wide local excision and then you go for your simple mastectomy.
Okay. Okay, ma'am.
I'm discussing this because you never read anything about oncoplastic surgery.
So ma'am talked about Gaylord-Thomas
Okay.
incision. So you give it in which part of the submammary area, medial, lateral, or central part? And why? When you make an incision in the submammary area, in the crease,
Yes, ma'am.
where do you make this incision, laterally, medially, or in the central part? So it is made laterally.
Which one will be better? Just think and answer. Just
Lateral.
think
Because
and
of
answer.
Yes, ma'am. Lateral will be better, easier to raise the flaps and reach.
vascularity is better. So healing will be better.
Okay. Okay, ma'am.
Because we take the flaps from there, no?
Yes, ma'am.
Okay.
What are the indications of radiotherapy?
Ma'am, if you're suspecting, ma'am, if you're suspecting if the margins that we have achieved are inadequate, and
No, that means if margins are not clear, you mean to say you'll give radiotherapy. You should revise the margins if margins are not clear.
yes, ma'am. Ma'am, if you're suspecting a malignant phyllodes, we can consider radiotherapy to the patient. If the patient has a prior history of chest wall radiation, we can also consider radiotherapy. And if you're also suspecting recurrence
Yeah,
from
borderline and high grade or spillage of tumor also during surgery.
okay. Okay.
Yeah. So I
Okay. Suppose this is malignant. Yeah.
No, that's okay, ma'am. Please continue.
Yeah. Now this is, suppose this is malignant phyllodes, right? So where will it metastasize?
Ma'am, it metastasizes by hematogenous route to liver and lungs, most commonly.
To liver and lungs or lungs and liver?
So lungs and liver, lungs most commonly, and followed by liver, ma'am.
Liver is very rarely involved. No, it's going to be lung, then bones and brain and
Bones. It is the bones, liver and the bones.
Yes, ma'am. What-
Okay.
actually, if you get a case of phyllodes and you don't talk about oncoplasty, that's not a very happy sign, right? In today's date, you have to know about
So I'll read about it, ma'am. Sorry, ma'am.
oncoplasty. It's a must-know area.
Sorry, ma'am. Read about it, ma'am.
Yeah, I think as far as phyllodes is concerned, more or less we've covered other things other than oncoplastic techniques. I think
Yeah, that's true.
are the anyone else has
But
any
then,
other
as Professor Srinivasan sir said, it is not all the typical of phyllodes. It's not huge. Then it's not. It doesn't have a bosselated surface. It doesn't have a variable consistency. He never said anything about the nipple, except the HPE. Yes, Piyush?
Yes, ma'am.
I don't know if you're right in saying it was smooth and all that. You said huge and then said 8 into 5 centimeters.
Yes, ma'am.
Okay. Anyway, Dr. Ratna,
I think
Babita.
yeah. So good attempt. Keep presenting. You must have a clinical image, right? And do not make wild guesses. If you're 50% sure, also still you can suggest and
Thank you,
come
ma'am.
out with an answer, but don't make wild guesses.
Okay.
And make a minimum data set for yourself as to what you need to present in history and examination in a patient with a breast disease.
Okay.
Relevant things like risk assessment and all should not be missed. And so these you should be able to tell also properly. And with respect to your slides, I think you need to read about what is a good PowerPoint presentation.
Yeah,
What
that
the
is
font
true.
size, yeah. What the font size should be, right? And which font should you which what is it called? Which graphics should you use, And something like an Arial black is supposed to be good for PowerPoint presentations. Your headings are very nice. Your images are good. But you did not have a clinical image. There's a scope for improvement, but you've done well. Yeah.
Thank you.
Ma'am.
Thank you.
Always keep a clinical photograph because we have not seen the patient. We are observing what you are saying. So it is better to have a clinical photograph with masking the patient's identity, eyes, everything. That will be ideal, I think. But whenever you are presenting a case, you have to read about both benign and as well as malignant cases in thorough in all the aspects. Because as a postgraduates, you are going to treat the patient, not like UGs. So you have to discuss, keep everything in the mind, both for benign as well as for malignant, and you should be able to answer. You don't know in which direction the examiner will lead on to you, depending upon your answers.
Okay. Thank you. Keep that.
Yes,
I
Piyush.
just want to-
Through you, this is a teaching session.
Yes, sir.
Through you, yes, the others are also getting their knowledge.
Yes, sir.
Okay, you are only an instrument in that. So you needn't worry. But only thing is, you said I think after you operated on the patient, only then you thought of presenting. That is why you are not able to tell it properly. Yes?
Yes, ma'am.
Yes, that is what even I thought. But then a little bit of cooking up here and there, you're not able to do justice. Anyway, that is why you should be sincere in examining the patient and eliciting the history first. Yes, if you had done that, then you would have presented really well. But it's a real good attempt, and I really appreciate you for that.
Thank you.
Okay, but the examiners can lead you on anywhere,
Yes, sir.
and you should be prepared for that. Got it?
Yes, ma'am.
Any questions that you have in mind that you want to ask? Any
No,
doubts that you had that you would want to clarify?
no, ma'am. No.
Okay.
Okay, Piyush, I'd just like to suggest a few things to you.
Is anybody from the advisors
Yeah.
or the team?
Piyush,
Yes,
I would just like to suggest a few things.
Yes, sir.
Like everyone said, your slides are below par.
Yes, sir.
Look, in your examination, the most important thing is history and physical examination, right?
Yes, sir.
Maximum marks is allocated to that. If you slip up there, then these kind of questions will start being asked about things which are around your mistakes, right? So that was lacking in your presentation. A thorough history and a thorough examination is what is the foundation for your further presentation of your case. It was very good that you presented your slides, like your pictures and all were very good, but there was no direction, right? Right. So if you think it's your case is Phyllodes, you have to go back to your history and examination and prove that by your history examination that can sorry, your first diagnosis is Phyllodes, and then these are your differentials, and then rule them out. Okay, right. I think very well done. Anyone else who would like to give an assessment on Piyush?
Yeah, I think all of
Srinivasan,
it.
Professor Srinivasan, I think is gone.
Okay, then.
Okay. Okay. Thank you, everyone. Thank you, ma'am.
We'll call it a day. Yeah. Thank you, sir.
Good
Piyush,
night.
Thank you, Ratna, Babita.
Thank you,
Pleasure
ma'am.
meeting you all, ma'am.
Thank you, ma'am.
Wonderful galaxy of examiners. Okay, Piyush,
Yes, sir.
very well
Thank
done.
you, sir.
Thank you, sir.
Right. Thank you. Good night.
Good night, sir.
Good night, sir.
Good night, ma'am.